Just for our website, yeah, did we check with you if that's all right?
I did check.
Yeah, no, that's fine. It's fine. Yeah. Did you want me to start?
Go for it.
Yeah. I've got some slides, so just give me 1 second because I'll share them. Yeah. And then people can then you'll be recording the slides, won't they? And yeah. You're right, it is strange talking to lots of initials. So yeah, I'll let me just make you small. And so I suppose one of the things to say is just, I suppose, to build on what Kat said before, there's lots of different units across Manchester. There's probably parents from lots of different units in this chat. There should be a lot of consistency really with the role of psychology. It should be one of the disciplines that's probably quite consistent across those different settings. So I know some people obviously might know me already, but so I'm Emma. So I'm the lead clinical psychologist for inpatient CAMHS at GMMH. So I work predominantly into Junction 17, but I have worked into Gardner unit as well, which is our medium secure forensic ward next door. And prior to working here, I worked for a couple of years at HMP Style, which is a women's prison, and prior to that I worked at Cheadle Royal at Russell House, which is the adult eating disorder service. So mostly kind of inpatient type roles. I think I'd be a bit of a loss if you put me in the community really. So yeah, definitely where I sort of feel at home. So psychology in the inpatient setting. So it would always form part of a sort of multidisciplinary team. You will usually have clinical psychologists, but you may also have counselling psychologists or forensic psychologists in that role. But people will be doing a very similar role across the setting. And every young person should have access to a psychological assessment in the inpatient unit. Now, that's very different to standards that lie in adult services. So in adult services, you may get access to a psychological assessment as an inpatient, but you also might not, particularly perhaps in the acute wards. So the wards that are maybe similar to sort of Junction 17 and Hope unit, that might not necessarily be the case in adult services. But I think we're very lucky in CAM services in terms of being more resourced. But also the psychologist staffing numbers are part of our core QNIC standards. Now, QNIC is the Quality Network for Inpatient CAMs. So for people who haven't come across that acronym before, that's I suppose an accrediting body ran by the Royal College of Psychiatry that sets out very clear standards for CAMHS units, and there are slightly separate standards for eating disorder units. I'm not sure if there's any parents from Altrincham or Galaxy House in the group, but also again for MSU. However, we are really lucky in that psychologists alongside psychiatry form some of those core standards, which means for units to be accredited, you have to have a psychologist, a qualified psychologist on the staff team. However, there usually isn't just one of us. We don't work in isolation. So you might meet us, so you might meet the clinical psychologists. We also have assistant psychologists that work with us who are often psychology graduates who want to get onto that doctorate training. And we also have trainee psychologists with us who are often, because of the specialist nature of the inpatient setting, they are often psychologists that are on their 3rd year of training. So they're kind of very close to being qualified, usually have about 8 years experience, either in psychology at uni or working with people by that point. This last one varies hugely, and I'm not sure what units people are from, but I think sometimes depending on what unit depends on how wide that psychology team is. So we are very lucky where we are in that we sit alongside the Gardner unit, which is an MSU, and we also used to sit alongside a sort of an 18 to 25s ward. So we might have a slightly bigger pool of staff that we sort of have been able to sort of develop over the years. So at Junction 17, every family would be offered access to a family therapist, but we do also have creative therapists on our staff team. So we don't have a drama therapist, but we have an art therapist and a music therapist. Now they work from a more psychodynamic model. That's an often a longer term sort of psychotherapy. So sometimes there might be young people that maybe come into the inpatient unit and they're likely to only stay on that kind of 4 to 6 week pathway. They will sometimes not have a referral into well, particularly music therapy, because it's that longer term model. But they might do if they've got a particular sort of interest or skill in that area. And I think one of the things that we really benefit from is when young people are very unwell sometimes when they come in. So thinking particularly of our acutely very unwell psychotic patients, who aren't at a stage where they can talk to us very easily, or they can't get their thoughts straight, or they feel very guarded. Our creative therapists usually have much more of a sort of successful impact early on. And there's, lots of sort of clinical evidence that we see for young people who are really struggling, but can sit at piano and can still play Adele that they've learned in the past, or pick up a guitar and play a guitar, as they would have been before they became unwell. And I think that's often very kind of grounding for people. It kind of brings them back to the skills. It's a bit like riding a bike. So I think if you are a young person who's very confused, very disorientated, very scared, actually being able to link back in with things that feel very comfortable to you, there's a benefit from that. Even if you're not able to make use of the therapy side of stuff, the activity in itself is quite grounding. So what are the admission goals? And I suppose, like Kat spoke about before, there might be people in this group who sit on very separate wards. So you might have a young person who's on a low secure unit where the average admission, I'm not sure, might be about 12 months, I'm guessing. Whereas perhaps a PICU or a general acute unit, like Hope or like Junction 17, the idea for lots of young people is to work to a sort of 4 to 6 week pathway model. So we look at admission goals that are, I suppose, achievable, but have the biggest impact during that time. So I'm hoping that everybody who's here, unless you've just been really newly admitted to the unit, has heard this word formulation before. But that's our main goal. So the main purpose, I suppose, of psychologists in the inpatient setting is to develop a psychological formulation, ideally with the young person and their family having input into that. If the young person isn't able to engage or doesn't want to engage, we will gather and collect that information as a team and share that with the family. But it is always my preference to sort of do that one-on-one with that young person to begin with, and then add in. For anyone, sorry if everyone already knows what it is, but I suppose just very briefly, it's sort of like a jigsaw puzzle or a roadmap of someone's presenting difficulties. And you may or may not hear psychologists talk about using different models of formulation. So for us, there's probably 2 that we use. So sometimes we use something called a compassion focused one that looks at, particularly when young people have experienced lots of trauma, we look at that, we think about the trauma, we think about the fears that might have led to in that young person, and then the coping strategies with that, and then the unhelpful consequences that might have sort of built up around that young person. So that would often be what we use if we've got a young person who maybe has experienced trauma, is engaging in a lot of risky, harmful behaviours towards themselves. But we also sometimes might use what we call a 5 Ps formulation, which is a more CBT based formulation that looks at sort of vulnerabilities, triggers, and then factors that we call, my brain's gone numb, maintaining factors, so things that keep the problem going. We also look at strengths, and it's often the bit that the young people struggle with the most. So lots of young people that are in hospital can't think of any, and we can often see them in the young person, and the family can see them in their young person. But sometimes it's just spending some time trying to think about what they are for people, and often they've got very lost in the sort of months leading up to an admission for people. So it's trying to sort of uncover those and build an understanding that means that people have understand why things have developed, but also what's keeping it going. And I know lots of the families, I've just literally just got off the phone to a mum who I'm sure she won't mind me saying whose daughter's just left the unit after a sort of 6-month admission. And she spoke a lot about sort of feeling like it was a place where she could take a bit of a breath while her daughter was with us, and take a bit of time to understand why things had sort of escalated to the point they were in order to be able to help better, rather than that constant, I suppose, what feels like firefighting when you're trying to solve problems and you're trying to support and you're exhausted yourself. So it's just being able to sort of take a step back and work out a little bit more sort of logically and rationally how all the pieces fit together. So yeah, so the main admission goal is the formulation, and that, my experience, and I don't think it's necessarily got any different over the years, despite there being a lot of investment in the crisis pathways and CAM services. Lots of young people that come to us, there isn't a formulation in place. There isn't something that's kind of holding and understanding and then driving care. And I think people obviously mentioned about discharge planning before. It should be the formulation that drives that care. That formulation should say, these have been the triggers in the past, these are the maintaining factors, and unless we reduce these maintaining factors or work consistently towards that, this problem isn't going to go away. So it should drive care and it should drive risk assessment. So it kind of continues on outside of the inpatient setting, and that should be what looks different compared to when somebody comes in. A sort of second admission goal for psychology in terms of lots of young people, and this isn't just for young people who maybe are engaged in self-harm or feel suicidal or have got emotional sort of dysregulation. This can also be for kids who maybe have had a psychotic episode, or young people who are hearing voices for other reasons, is around that emotional regulation and distress tolerance. So these terms are taken from DBT, which is a particular model of psychological therapy. So it stands for dialectical behaviour therapy. But they are kind of core across lots of models. And I think DBT has probably been a bit cheeky and like nicked stuff that people use across all different sort of models of therapy and kind of branded it. But they're two sets of skills that work together, really. So your distress tolerance is your in the moment sort of crisis survival skills. And this is what we do a lot with young people on the ward in terms of kind of safety planning. So I suppose for context, so grounding techniques might be things that people have come across before. You might find them in the safety plan that your young person works on with their keeners or with their psychologist, but they are things that, when things are very distressing, bring people back into the present moment. So maybe young people who have flashbacks, who get very distressed, young people sometimes who have kind of psychotic experiences, so perhaps hearing voices or seeing things. Grounding techniques are those strategies that bring you out of that experience and back into the here and now, and in the hopes that the here and now feels more safe. So just for context, those things might be when you've heard people talk about 5, 4, 3, 2, 1, so the exercise where you would get someone to look around the room and say 5 things that they can see, 4 things they can touch, 3 things they can smell, 2 things they can hear, 1 thing that they can taste, that sort of thing. Everyone has their preferences. That tends to be one that people use a lot because it's easy to remember. If you've got a really bright kid, sometimes you need something a bit more cognitively testing for them. So it's like something that taxes them a little bit more is helpful. So counting back from 100 in sets of 3. Looking around the room and naming something beginning with each letter of the alphabet. And if you can do that reciprocally, I can never say that word, taking it in turns, that's even more grounding because you're using that relationship then to do that. So I might say A, looking around my room, I'm gonna be able to think of it now, arm, but you might say B and you can see a ball and it just moves back and forward, and again that's just bringing people back into the present moment. Tip skills, again, is another very popular sort of DBT skill, and this is used when kids get very dysregulated, perhaps, so like very pacey, very angry, very agitated, and physiologically it works on the body, so it brings down that physiological arousal. So It's going to test me now because I haven't written it down, but the T stands for temperature. So it could be like splashing really cold water on your face, having a cold shower, which is impossible in an inpatient setting because you can't have freezing cold water come out your shower. The I is intense exercise, so like just jumping jacks, running up and down. And the P's are, mine's going blank. One of the P's is progressive muscle relaxation. And the other one is paced breathing. So the breathing exercises. So again, all the physiological things that sound dead basic. And when you say to kids, go and do some breathing exercises, you get a bit of a like an eye roll. And if it was that simple, I'd have done that. But it does have a physiological impact on a body. So it should be something that does just work if people will give it a go. And then self-soothing, so things that are comforting. So often your young person will probably come home with a self-soothe box that they've made on the unit that's got some fidget items in, but also got some sensory. And if you've got a sensory OT on the ward, then that should be quite a sensory. It should be based on your young person's individual sort of sensory profile. So they're all just surviving. And someone once said to me, it's like keeping your hands and heads busy to survive a crisis. They're not things that are going to change things longer term for people. It's just getting through those like urgent moments. And then the emotional regulation skills is the other side of that, which is your sort of longer term coping skills. So lots of like name it and tame it. So we get lots of kids that maybe don't know how they're feeling. They can't put it into words. Trying to help them build connections between feeling a certain way and what the trigger was. And again, as adults, often that sounds really obvious that we kind of know if we've had a bad day, we usually know why. But for young people, sometimes they don't have that and they need that sort of scaffolding to sort of build that understanding. So actually, if you feel really stressed, what are the things that have stressed you out, like, and actually being able to sort of name that and make connections, communicating feelings safely with others, so being able to actually be angry, because often we send messages that, particularly in schools, well, you can't feel like that, you can't act like that, and actually it's about understanding it's okay to be angry. It's not okay to hit people, it's not okay to damage things, but being angry is fine. And it's just about trying to find other ways to project that or to put that out there safely. Self-compassion, people will know what that is, but just that sort of treating yourself with kindness, treating yourself how you treat other people, and then doing things that are positive. And again, it sounds really simple, but when people have been very low in mood for a long time or very stressed, often the things that drop off are the things that make people feel happy. So actually trying to work with people to think actually it's okay to do these things. And we get a lot of young people come through the inpatient setting who maybe experience grief. Worked with a young person last year who'd lost her dad, and actually stopped doing anything that was nice because of the guilt she felt if she did anything nice and what that must mean about her and her relationship with her dad. So doing some of that work to think about you can be happy and still be grieving. So that would be how we would think about positive emotions, rather than these kind of some of the toxic positive psychology stuff on there about, just fake it till you make it kind of stuff. It is about genuinely finding experiences that make people feel happy. And then I suppose another one would be about looking at relapse prevention. So this is the type of intervention you would look at in more detail if you've got a young person who's experienced psychosis, or young people go on to get a label of schizophrenia or bipolar, and or any kind of mania presentation where people sort of have more distinct episodes of being unwell. And this is a really detailed plan that we would build collaboratively with the young person. These are really hard when young people aren't at that stage yet or aren't ready to engage, because a lot of what goes on in psychosis and mania is inside the young person's mind. So in terms of looking out for triggers and of illness and distress, you need that level of engagement really and insight in terms of being able to pull that together. And I think what's often interesting is the things that the young person puts on this plan is often very different to the things that a family might put on a plan or what professionals might put on a plan, because what we see and our experience of that young person and their illness is often really different to each other. So again, it's important for everyone to sort of have input into that plan, and it can be a really tricky intervention. So if you're a young person who hasn't been well in this way, sometimes you might have done things that you're embarrassed about, or you don't remember, feel shameful about, don't believe, and just gently trying to build that understanding of actually these were the things that happened in a way that's not embarrassing and shameful. It is usually a big part of this intervention. But they would have really clear, so we have that it'll have something within it called a relapse signature if you've had a young person who's been psychotic, which would look at what that looks like. So exactly how does that young person present when those symptoms are developing, in the idea that they would be caught really early should they start to develop again. And this is something that someone would work with their early intervention worker, for example, to keep revisiting, because that it might be something that changes over time, and it would have really clear behavioral actions, things on there that we would want the young person to do, and if they couldn't do them, the things we would need family to do, and if the family couldn't do them, the things that we would need professionals to step in and do if those warning signs were developing again. But again, it is usually, if you're thinking, oh, I've never had one of them for my young person, it is usually quite specific for psychosis, and sometimes young people with eating disorders might have a plan that looks a little bit like this. I suppose just to finish, I could talk for England, so I'll just wrap up on this last slide. Often people will ask a lot about, will my young person get therapy on the ward, and what does therapy look like? And that looks very different depending on the setting, sometimes the therapist themselves, and then what I would say is what your young people will often not get is a trauma-based therapy in a hospital, in the sense that we would very rarely do any sort of reprocessing or exposure type therapy work in a hospital setting. Now, that doesn't mean it shouldn't be done, or it can't be done. And if you have a young person that's maybe on a low secure unit, I've certainly done it with some of the boys I've worked with who have been prison transfers onto our MSU, and we've got them. We know how long we've got them. We know how long the warrant, the Ministry of Justice licenses. You might do it then. So it's if you're having it, don't think, oh God, they shouldn't be having it. But it is just about, sometimes you can start that and that can take an incredibly long period of time. Sometimes it can be really destabilizing for people. But that part of the therapy is often the end anyway. So actually, if your young person is in hospital and they have experienced trauma, and the work they are getting is very skills based, so it looks like emotional regulation type stuff and the distress tolerance we talked about, that's often just that first bit in terms of stabilization, which many trauma therapists would ask for anyway first. So it's a big chunk of the work that can happen that stabilizes someone to be able to do that sort of longer term therapy, where they might go on and access like EMDR or trauma focused CBT. But again, that can vary quite wildly. So I did a lot of that when I worked at Cheetah Royal, and I worked on the eating disorder ward. I've done it a few times on Gardner with our longer term forensic patients. I am EMDR trained, but I've never done that processing work with one of the young people on the shorter stay wards. But I have done a lot of the stabilisation work that sort of precedes that, for young people to then go on and do that work when they move into the community. That's me.
Thanks, Emma. I will stop the recording, and then we can everybody can turn their cameras back on and ask